Yes, we can see the slides now.
Okay, yes, thank you very much. I'm sorry for this delay. It's a pleasure to have a chance to see, although in a virtual setting, colleagues and friends, and to discuss an issue which is of persisting interest in hypertension. That is the role of sympathetic nervous system in hypertension. Now, let me start by saying that there is strong evidence that sympathetic activation can cause hypertension in animal studies. In a variety of animal models in which emotional situations were chronically induced, in monkeys, in mice, in other animal species, this was capable of starting hypertension and determining a chronic hypertensive state. Now, the evidence in men is much less strong. An increase in blood pressure has been reported in job characterized by stress, blood pressure variability, which is an important factor in hypertension, has as a co-cause an increase in sympathetic activity. There has been a description of hyperreaction to stimuli, but not consistently. But all these types of evidence are not really the final evidence we would like to have. But on another line, evidence has been collected by several investigators, and it is quite strong. And this evidence has made use of the only technique which allows to record the sympathetic nerve traffic directly in men. And this is so-called microneurography, use of a microelectrode inserted in the peroneal nerves or the brachial nerves in order to detect sympathetic firing, which is, you can see, related to blood pressure. It's a difficult technique, but very reproducible, and indeed very nice to try to study sympathetic nervous system activity, not only in hypertension, but in a number of other conditions. Now, our group started to use this technique already many years ago. There were 3 or 4 laboratories around the world using this approach, and described that systole-diastolic hypertension and isolated systolic hypertension in the elderly, compared to normotensive subjects, were indeed characterized by an increase in sympathetic nerve traffic. And you can see traffic was greater in both conditions compared to that found in normotensive patients. Now, several other studies have been performed, and all of them have shown that the sympathetic activation, which can be seen in hypertension, is an early phenomenon. You can detect it in the early phases of hypertension. You see at least 5 studies showing that sympathetic activation can be seen in borderline hypertension in individuals still normotensive, but with the family history of hypertension and pre-hypertension, and so on and so forth. Let me give you some example. This is a study on high normal blood pressure, a pre-hypertensive condition, because it is characterized by a greater risk of developing hypertension in future years. And you can see that in individuals with high normal blood pressure, sympathetic nerve traffic is greater compared to individuals with lower blood pressure values, normal blood pressure or optimal blood pressure, that is blood pressure below 120/80 millimeter of mercury. And then there is another condition which is preparatory to hypertension. And this is white coat hypertension, but also masked hypertension. Now, we showed several years ago that both white coat hypertension and masked hypertension are characterized by much greater risk of developing over the years a true hypertensive state. You can see here that when patients were restudied 10 years later, compared to individuals with normal blood pressure, those with white coat and masked hypertension had more than double the incidence of moving to sustain hypertension. And this was the case both when white coat hypertension and masked hypertension were defined by office versus ambulatory blood pressure and by office versus home blood pressure. These are data from the PAMELA study. And both wide coat and masked hypertension, preparatory as they are to a sustained hypertensive state, as you can see from this study from Professor Grassi and his group, are characterized by an increased sympathetic nerve traffic, which is very similar to the one which can be found in individuals with sustained hypertension compared to truly normotensive individuals. Then there is another phenomenon which has been studied and on which there is now evidence, and this is that the increase in sympathetic activity, which can be found in hypertension, is progressive in magnitude with the increasing severity of hypertension. No matter how we detect the increasing severity, by a progressive blood pressure elevation, by appearance of organ damage, or by association with other risk factors. And let me show you some example. This is a study in which we look at individuals with different blood pressure levels within a hypertensive state. And of course, you can see that the greater was the blood pressure level of hypertensive condition, the greater was the sympathetic nerve traffic. And this is a recent meta-analysis of available studies on muscle sympathetic nerve traffic and hypertension. And you see the same phenomenon, a progressive increase in sympathetic activity from normotensive individuals to borderline hypertension and essential hypertension. Now, the highest magnitude of sympathetic nerve traffic within the hypertensive state, which we have seen, is that of individuals with resistant hypertension, a condition characterized by large magnitude of organ damage and a high risk. And you can see in this study that individuals with resistant hypertension compared to individuals with wide coat, with hypertension but sensitive to antihypertensive drug treatment, they are characterized by a greater increase in sympathetic nerve traffic. So from a condition of normotension to a condition of progressively severe hypertension up to resistant hypertension, there seems to be a progressive increase in sympathetic activation. Now, another way of characterizing the severity of hypertension is the presence of organ damage. And evidence from several groups, including a very well-known group to which we know a lot of information on this issue, Professor Esler and co-workers in Australia, have shown that individuals with hypertension and organ damage have a greater sympathetic activation compared to individuals with hypertension but no organ damage. And this is a study by Professor Grassi from our group in Milan on this issue, showing that individuals with hypertension and left ventricular dysfunction have greater sympathetic activation compared to individuals with hypertension, matched for age and gender and other clinical characteristics, but without organ damage. In both of them, sympathetic activity was increased compared to normotension, but the increase was greater in individuals with cardiac damage plus hypertension. And then the third way of detecting a greater risk in hypertensive individuals, a greater severity of hypertension, is association with other risk factors. And we did a lot of studies looking at sympathetic activity in hypertension and associated comorbidities, such as, for example, obesity, such as sleep apnea, and several other conditions. Here you see, for example, that individuals with hypertension plus metabolic syndrome compared to hypertension alone without metabolic, they had an increased risk of having greater sympathetic nerve activity. And this was the case both in treated hypertensive patients and in untreated hypertensive patients. The final condition I would like to show you on this specific issue is a condition also characterized by greater risk. And this hypertension in which patients do not exhibit reduction of blood pressure at night, which is a protective effect. the so-called reverse dippers. Nighttime hypotension is replaced by nighttime hypertension, the so-called reverse dippers. And you can see that in reverse dippers, incidence of cardiovascular events is particularly high. Well, you can see in this study that individuals with reverse dipping phenomenon, they seem to have a greater increase in sympathetic nerve activity compared to other hypertension phenotypes. Now, the other issue I would like to include in my presentation is just a few words on what could be the cause of sympathetic activation in hypertension. Probably we should talk not about the cause, but about the possible causes, because several mechanisms and factors may be involved in sympathetic activation. Central factors increasing sympathetic activity, dysfunction of reflexes normally taking sympathetic activity down, such as the baroreflex or the cardiopulmonary reflex, chemoreceptor activation. There is nice evidence about this by groups of investigators in Poland, for example. But attention today is particularly directed to interactions between different control mechanisms in the cardiovascular system, which interact in a positive fashion. For example, we know that angiotensin II stimulates sympathetic activity, and in turn, sympathetic activity can increase renin release from the kidney. So there is a sort of a positive feedback system. But another positive feedback system is that between insulin and sympathetic nerve activity. Insulinemia can stimulate sympathetic nerve activity, and increased in insulinemia is accompanied by sympathetic activation. But in turn, sympathetic activation can create insulin resistance, which leads to a further increase in insulinemia. So it is possible that we have a sort of a number of vicious circles here. We have, for example, an insulin resistant state, and this leads to sympathetic activation and so on and so forth. And the same for increase in the activity of the renin-angiotensin system. Now, let me say that sympathetic activation is not a prerogative of hypertension alone. Many other conditions are characterized by sympathetic activation. Some conditions unexpected only a few years ago, for example, hepatic cirrhosis, for example, anorexia. But some conditions are very well known to be accompanied by sympathetic activation. One of them is heart failure. Heart failure is accompanied by very marked sympathetic activation. And the greater is the severity of heart failure, the greater is the concomitant sympathetic activation. Obesity is accompanied by sympathetic activation. Sleep apnea is accompanied by sympathetic activation. And several other conditions are accompanied by sympathetic activation. Something very interesting and not yet well known is that the sympathetic activation associated with all these conditions I mentioned does not involve all circulatory regions. For example, in the skeletal muscle, conditions I mentioned before are all associated with an increased sympathetic activity, but the skin is preserved. As you can see, hypertension, obesity, heart failure, metabolic syndrome, and so forth, never we found an increase in skin sympathetic activity. And we try to understand why this is the case. And the only explanation, speculative, we could come up is that skin is so vital for thermoregulation that the organism takes care of not involving skin vasomotor control in some derangement. We could really endanger thermohomeostasis. Now, do we have evidence that sympathetic activation is a risk factor for cardiovascular events and death? Well, in a number of conditions that have been studied, and studies do show that sympathetic activation has a negative prognostic significance. For example, heart failure. The greater is the sympathetic activation, in this case, elevation on plasma norepinephrine, the lower is survival. This is true also for the post-stroke state and for the renal failure state. In renal failure, the greater is the sympathetic activation, the lower is survival. In hypertension, this evidence is not available, but we do have evidence that sympathetic activity has a direct producing role in the organ damage accompanying heart failure. This is an example in animals, but there are many other examples I could show you. In this animal species, I thought there were cats, no, dogs. What was done was to infuse norepinephrine at subpressor doses, that is, doses that did not modify blood pressure. But despite absence of blood pressure increase, norepinephrine was capable of increasing the volume of myocytes and producing left ventricular hypertrophy. And in several other organs, evidence has been collected that there is a direct damaging effect and alterations in the structure of the organ by sympathetic activation. Now, our group has been involved over the years in the control of arterial distensibility by sympathetic nerve activity. And we came to the conclusion by a number of studies, as you can see, that sympathetic activity has a stiffening influence on the large and smaller arteries. In animals, stiffening, the arterial distensibility was increased by removing sympathetic influences by chemosympathectomy, both in the carotid artery and the femoral artery. And by using some human models, we were able to see that this is the case also in men. For example, in individuals undergoing brachial plexus anesthesia because of a surgical intervention against the Dupuytren disease, radial artery distensibility was increased after removal of sympathetic influences by brachial plexus anesthesia. And this was the case in the femoral artery by spinal cord hemianesthesia in individuals undergoing arthroscopy of the knee because of meniscal lesions. And finally, two other studies were one on increase in femoral artery distensibility by unilateral lumbar sympathectomy, or in individuals with heterotransplantation of the hand, radial artery distensibility also increased. So when the sympathetic system is functioning and in place, arteries are stiffer. And please let me remind you that stiffening has an enhancing effect on atherosclerosis production. So all this would lead to the conclusion that it might be beneficial to reduce sympathetic activity by antihypertensive treatment. And in this study, as you can see, evidence was shown that compared to untreated hypertensive individuals, sympathetic activity can be reduced by different types of treatment. Probably it is an effect of blood pressure reduction rather than an effect of the specific drug employed. But you can also see that the reduction doesn't normalize sympathetic activity, which remains above the level we expect to see in truly normotensive individuals. Now, does this reduction increase the benefit of treatment, or it is accompanied by a beneficial effect of treatment? Well, trials do not answer this question. In the past, we had trials in which acting on sympathetic influences on the cardiovascular system was not accompanied by beneficial effect. Alpha blockers, for example, in the ALL-HET study, or in heart failure, the moxonidine study. But both studies had problems of interpretation, but unfortunately, no further studies are available. And another way of reducing sympathetic activity, central agents, there have never been dedicated trials to see what happens if sympathetic activity is reduced by central agents. But we do have, on the other hand, evidence from one class of drugs, and this is beta blockers. Beta blockers reduce sympathetic activity, especially to the heart, but not only to the heart. And in a meta-analysis limited to hypertensive randomized clinical trials, which we published 2 months ago, as you can see, reducing blood pressure by beta blockers was accompanied by reduction of stroke, coronary disease, heart failure, and so on and so forth. So evidence is there, but more evidence by other ways of reducing sympathetic activity would be highly desirable. Thank you very much for your kind attention.
Thank you very much, Dr. Mancia, for this excellent presentation. Actually, we were just talking beside you that how to diagnose it. I mean, we all know that maybe tachycardia, maybe sweating, excessive sweating. What do you use criteria for the diagnosis of hypersympathetic activity?
And this is a great question, but it's a very difficult question because one of the problems we have is that at the bedside, there are no ways of quantifying sympathetic activity except for heart rate. Now, Professor Grassi and our group has shown in several studies that there is a satisfactory relationship between increased heart rate and increased muscle sympathetic nerve traffic, which suggests that an increase in cardiac sympathetic activity is accompanied by an increase in vascular sympathetic activity, peripheral sympathetic activity. But except for heart rate, which of course we should remember, it's also under vagal control, we lack accurate methods to detect an increased sympathetic activity in clinical practice. This, for example, is a big limitation in the use of renal denervation. If we think that patients with an increased sympathetic activity are those who can benefit more of renal denervation, but we lack a satisfactory tool to detect whether there is such an increase in sympathetic activity in patients.
Thank you very much, Professor. I'm an internist, and still my basic knowledge is that when there is sweating with hypertension, to think of pheochromocytoma or thyrotoxicosis and hypertension. How would you consider these among hypertensive patients, as you said, with sympathetic overactivity?
Is the question whether sweating is a surrogate measure of sympathetic activation? Sorry, just to be sure that...
many people, they come to the physicians complaining of profuse sweating, particularly in the night, nocturnal.
But I don't think there is any evidence that sweating is something which has to do with sympathetic activation. And the other finding I would like to mention, and this is a very nice finding by Professor Ersler and his group, is that the behavior of adrenal glands and peripheral sympathetic activity can be different. There are several conditions, including hypertension, in which there is an increase in sympathetic activity in several areas: the heart, the kidney, not the skin, as you have seen, but the heart, the kidney, and the viscera, yes, but not the adrenal glands. So the old concept back in the 20s of the past century, that whenever sympathetic nervous system is activated, the activation is generalized, doesn't hold. And there is in particular discrepancy between adrenal gland activation and activation of the sympathetic nerves.
Professor Mancia, thank you so much. It's always a pleasure to attend the lecture of the great Mancia.
Thank
My
you.
question to you, where do you find the role of beta blockers in the guidelines? Would you expect to have a different role in the future?
I think the role is and will remain important. In the European guidelines, if you read the text, there is clear mention that beta blockers do have evidence of protective effect in placebo studies. And by and large, total cardiovascular risk reduction is more or less similar with beta blockers and other drugs. And in addition to this, in the medical world, moving to precision medicine, beta blockers can be regarded the preferred drugs in a number of important conditions. Some of them are listed by the European guidelines, for example, symptomatic angina, heart failure, post-myocardial infarction state, heart rate control in individuals with a heart rate above 80 beats per minute. But not only this, there are many other conditions in which beta blockers are important. For example, thyrotoxicosis, for example, aortic aneurysm, and essential tremor. So in the future, in which we will struggle more than we do now in finding the proper drug in any individual patient, personalized treatment, I think we will continue to need beta blockers.
Dr. Mancia, this is Mohammed Sobhi speaking. Thank you very much for this lecture. I'm extending the question of Dr. Abdulghani again. I don't know how much sympathetic hyperactivity or overactivity in each hypertensive patients. Number two, is the ambulatory blood pressure can detect tachycardia together with hypertension to see how much sympathetic overactivity. And in one of your slides showing the effect of treatment, that if you give ACE, ARBs or combination, it doesn't make abolition of or to terminate the sympathetic, there's still some sympathetic hyperactivity. Do you think that because we don't know how much sympathetic in each hypertensive patients, we can combine ACE or ARBs with beta blocker to each patient because you don't know? Or there is a way, something like ambulatory blood pressure, which can lead you to have some tachycardia, and so you have some stimulus of sympathetic overactivity. So how can you make it like this? Because this is now we are in dilemma. In the past, we have low renin, high renin, normal renin. We don't have now. We don't measure noradrenaline except, as Dr. Fuad said, the 5 chromocytomas. So how can you make it and evaluate it in terms of treatment?
Well, I think it would be nice to base treatment on mechanisms or differences in mechanisms. But this is only possible in a limited number of clinical conditions, as you say. I mean, we don't have ways of measuring accurately the sympathetic status in patients. The renin-angiotensin system activity has been shown to be worthless, unfortunately. Hemodynamics is very monotonous or homogeneous in hypertension. I mean, most patients have an increased systemic vascular resistance with no increase in cardiac output or even a reduction in cardiac output in the elderly. So we have to base treatment empirically on the protective effect of different drugs. And fortunately, we do have evidence from a huge number of studies that 5 drug classes are protective. And as you know, these are certainly blockers of the renin-angiotensin system, but also diuretics, but also calcium channel blockers, and also beta blockers. And certainly combination treatment, including combination of a beta blocker and an ACE inhibitor. Now that combination treatment is recommended as the best treatment strategy in most patients, can be considered because not only because of the potential reduction in sympathetic nerve activity, but also because of this is the best treatment in patients with coronary artery disease or a history of coronary artery disease and several other conditions. But the choice is hardly based on trying to individualize the mechanism responsible for a given condition, with only one exception, and this exception is an increase in heart rate. We do have evidence that when heart rate is above 80 beats per minute, sympathetic activity is increased to a particularly marked degree. And this is true for office tachycardia, but also for 24-hour tachycardia. And so in these conditions, I think that adding a beta blocker to other drugs to control blood pressure can be justified.
Professor Mancia, thank you very much for this excellent presentation. But I have a short comment about the role of ambulatory blood pressure to detect the sympathetic overactivity, as evident by nocturnal non-debar or nocturnal hypertension or orthostatic hypertension, morning surge of the blood pressure. All these may be a marker that the sympathetic overactivity plays a role in such a patient. My question about the target heart rate, we always speak about the target blood pressure in our patients. What is the target heart rate in hypertensive patient? This is number one. The second question about the what's called paroxysmal sympathetic hyperactivity, previously called dysautonomia. Is the rule of what is the rule of paroxysmal sympathetic hyperactivity in hypertension?
Well, there is no guidelines because there are no studies. And we have no studies on the target heart rate in hypertension. There is some evidence in heart failure that the higher the baseline heart rate, the greater is the effect of drugs lowering heart rate, beneficial effects. But in hypertension, we do not have these data. So the recommendations is based on the fact that in individuals with heart rates, for example, greater than 80 beats per minute, sympathetic activity is particularly high. And it seems logical to try to control heart rate together with blood pressure. But if you ask me whether there is a trial confirming this and telling us what is the target value for heart rate, my answer would be no, there is no trial of this kind. But please notice that many recommendations by guidelines are not based on trials. A few years ago, I published in the Brownwald book a paper, a chapter in which I look at the number of recommendations by hypertension guidelines or cardiology guidelines based on trials. Less than 25% recommendations were based on trials. The other were based on lower levels of evidence or even expert opinion.
Okay, thank you very much, Dr. Mancia, and we will see you again in the other sessions. And we have to move now because of time. The speaker, the chairman, please, of the second session, come, please.